So, good morning and a warm welcome to all the dignitaries present here. Myself, Rupsha from Clarinet, assigned as a session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet is the digital partner of this event organized by Karnataka chapter of IACTA, Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation. And the topic of today's session is echocardiography in heart failure. So just allow me a moment to play a short video.
Good morning and welcome to the Sunday TEE session, which we also call as breakfast session. It is being conducted under the auspice of Karnataka chapter of IACTA, Indian College of Anaesthesiologists, Indian Association of Cardiothoracic Surgeons, International Society for Cardiovascular Ultrasound, Global Heart Care Foundation, and Global Intensive Care Symposium. Today, I'm really pleased to have a distinguished faculty amongst us, Dr. Murali Krishna from Chennai, Dr. Rahul Guha Biswas from Kolkata, and Dr. Aditi from Bangalore. And today's topic, as already mentioned, is echocardiography in heart failure, and we are looking forward to a great presentation followed by interaction. Please post your questions and comments in the chat box. We'll try to address all the questions at the end. And if you want to speak, please unmute your mic at the after the talk, and you may introduce yourself, and you can be online. With that, I would request Dr. Rahul Guha and Aditi Singhvi to take over and go on with the presentation. Rahul is well known. He's from the Rabindranath Tagore Institute of Cardiac Sciences in Kolkata. And Aditi is in Narayana Hrudayalaya, Bangalore, the main hub of Narayana Health. She is the advanced heart failure and transplant cardiology clinical lead, and she's extensively experienced in the field of treatment of heart failure. And we are fortunate to have all the three experts here. And with that, I would like to request Rahul and Aditi to take over. Thank you so much.
Thank you, sir, for your very kind introductions. We won't take much time. I only want to say a lot of things are happening in the field of heart failure and transplant, and I'm deeply honored to be with some of the most eminent physicians in the field of heart failure and transplant. And Dr. Murli, who's very well known in our circle and in the field of heart failure, will today be deliberating about the recent developments and updates which are happening in the field of echocardiography. Over to you, Dr. Aditi.
Good morning, everyone. Thank you, Murli sir. Thank you, the moderators, for giving me this opportunity.
Dr. Murli, 1 minute. If Dr. Aditi wants to say a few words before
Please.
we start. Yeah.
I think, this is a great opportunity for us to learn from eminent experts in the field. There are several new developments in the field of echocardiography and heart failure, whether we are talking about acute heart failure, cardiogenic shock setting, intraoperatively, as well as chronic heart failure. Newer applications, including better quantification for valve lesions, that is assisting with procedures and interventions also now to strain imaging. And now the latest is using AI to help us better understand pathologies and help us in better management of various pathologies. So we learned from Dr. Murli sir now of his opinions and latest views.
Good morning, everyone. I'm Dr.
Yes.
Good morning, everyone. I'm Dr. Murli from MGM Healthcare in Chennai. My sincere thanks to Kanchi Murli sir for this opportunity, and Dr. Rahul and Dr. Aditi for chairing the session. I'll directly go to the talk. Is it visible? Slideshow,
Yes.
and my voice is clear?
Yes. Yes.
Right. Over the next 30 minutes or so, I'll be dealing about echo in heart failure. This talk will be roughly a kind of a basic talk. When we look at echo in heart failure, you're talking of a varied spectrum of patients, the patients who are having heart failure. And echo in them, as we all see, helps us in multiple ways. First, obviously, the establishing the diagnosis that this particular patient has a heart ailment. From there, looking how they are going to go. Is this disease is going to progress or not? Is there a response to therapy? What can be the possible prognosis in these patients, and how to go for further therapies, whether it is your medical management, or at what point we should consider the surgical options in these patients. It has a whole lot of utilization. But for the limited amount of time, I would like to limit myself to this particular subset, the patients who are having a severe heart failure, who are already diagnosed elsewhere or some already diagnosed in your same place. But once they come first to the advanced heart failure clinic for further management, whether it is medical or surgical, how are we going to go with them? These patients are the ones who are already diagnosed earlier, and now either they come as an elective patients to you to further work up and take it forward, or you're seeing a patient first time who comes right with you in decompensation. So this includes handling the decompensation, evaluation of these patients, and handling any new problems that do come when you manage these particular patients. Obviously, management of this kind of patients is based upon multiple factors will come into play, not just any single parameter. And even when you talk specifically about imaging in decision making in these patients, echo is just one of the tool. It's not all in all. We should keep in mind that's always a multimodality imaging. And let us come back to our talk, like where does echo make a role in heart failure these patients? One, identification of your different etiologies for your heart failure. That's one. Second, it also helps you as a hemodynamic assessment tool when you use echo for handling crisis in these patients. Third, equally important, is optimizing them. The next is decision making. And if you have a situation in this patient, how does this help as an aid in handling this situation there? So let's first look into the etiologies or the different types of cardiomyopathies, what we commonly see. We'll not go in detail, but these are the common ones. You have the most common being the dilated cardiomyopathy, whether it is ischemic origin or a non-ischemic origin. That's the most common one you see. Can be either a single ventricle, that is most common being the left ventricle, or it can be a biventricular dysfunction by the time you see the patient or to start with in this one. The second common what we see often is the restrictive cardiomyopathies, where you have the ventricle being thick with some infiltrative or some hypertrophic pathology, where there is a severe diastolic dysfunction and a largely dilated atrium with a very high filling pressures you see, or a hypertrophic cardiomyopathy, that is the other common type, where you see the heart as with the LV being very thick and having an issues with the mitral or LV outflow tract in these patients. Or as the disease progresses, this hypertrophic cardiomyopathies usually go to a burnt out phase, where they more or less resemble like a dilated cardiomyopathy, where they go for a severe systolic dysfunction and a thinned out and a dilated heart in this. Apart from this, you see in a non-compacted cardiomyopathy and ARVDs. ARVDs are where you have an isolated right ventricle, which is hugely dilated, and a non-coapting tricuspid valve. And these patients are more prone for arrhythmias. The ones which is not discussed at are the complex congenitals, where no further medical or surgical option is available, and this particular patient has to go for a transplant pathway in the advanced heart failure clinic. So with this, let us see what do we do in an echo in an initial assessment when you see this patient for the first time. Of course, you do look at what is the underlying disease etiology or the pathology, how bad is the particular disease involvement, how severe is the heart failure signs or a systolic or the diastolic dysfunction. Along with that, you do a very simple basic assessment of your heart failure compensation or a decompensation in this. That includes your initial hemodynamic assessment, looking at possible filling pressures of both left side and right side, and along with that, getting an idea of pulmonary artery pressures to see how is this patient to further titrate your therapy. Along with that, you also look at, are there any signs of decompensation? When you see signs of decompensation, what you are specifically looking at echo are any effusions, that is a pleural or a pericardial effusion or an ascites in this patient. So this tells you whether this patient needs right away some further aggressive therapy where you can compensate them and try to settle them and take it further forward with a medical therapy or further evaluation in these patients. Also, it's always important to look for this in these patients in wherever there is an area of stasis, whether it is a ventricle or an atrium, to look for possible clots which can have troublesome presentations in them. So once you do an initial assessment, a hemodynamic assessment of these patients by your echocardiography, and if you identify any decompensation, you try to handle that, serially follow them, make sure that the heart gets slightly better or the decompensation episodes are handled. Then you go for your next step in these patients, where do you use, where you go for a decision making. So let us look at how an echo can guide us or help us in this process of aiding in the decision making of these patients. So to go in gross, these are the options which you have for these patients who are like you have in a medical option where you can manage them medically. These are the scenarios where you can have the patient is stable enough, he can wait for any further therapies, or he's unstable, but there is still some room where we can optimize him, the one who presented with decompensation, not of enough medical therapies. So you try to compensate the patient first, and once you stabilize him, you further continue the medical management in this patient. Or this may be the only option considering various other factors. You cannot consider a transplant or a VAD, whether it is a clinical or a non-clinical parameters that influence this, the medical management being the only option. Apart from this, if you look at surgical, these are the two major, a transplant, a heart or a combined heart and lung, or a VAD. These are the options we have. So before we choose any of this option, the decision is based upon multiple factors that come into it, but two major factors which you take into account when you choose one of these pathways, these two. One is the right heart hemodynamic data, or the CAT study, what we call it, and second is the echo. So what is a right heart hemodynamic or a CAT study? Basically, you try to get the filling pressures of all the chambers of your heart, starting from the right atrium, right ventricle, pulmonary artery, the LA pressure, or you try to get a wedge pressure, and you get a lot of derived values, starting with your cardiac output, then vascular resistance, both systemic and pulmonary vascular resistance, right ventricular stroke work index, and a lot of other what you derive from that, RVW, RVSW, AP, API, all these what you derive from that. Then you measure the saturations. Then you have comprehensively like what is summed up in this report in front of you, what is the hemodynamic data of this patient. So let us come back the focus of our talk, like how does echo makes a difference in the heart failure. So when you talk of the role of echo in this specific context where you're talking of assessment of the patient with a right heart cath and an echo, these are all the ways in which an echo can play a role. Like one, to confirm or aid your right heart data, and to decide along with your right heart data what this particular patient needs, and identify the different other trouble scenarios. So let us look at one by one in detail. First, you're guiding the right heart cath procedure. So what do we mean by guiding the right heart cath procedure? First and foremost is the appropriate timing. And as we have seen before, these two are your major things which will decide what is going to be the possible options, or what can be the possible course for this patient, whether he can be transplanted or not, he needs something or not, kind of thing. So appropriate timing is very essential in identifying the appropriate timing when you should do the right heart cath. So that's basically decided both by your clinical judgment along with the echo. As we have discussed in the initial part, if your patient is having a decompensation, we should ideally wait and try to compensate the patient, settle the decompensation episode before we proceed for the right heart cath. So you serially follow them both clinically and echo-wise and identify the appropriate time when you're going to do the right heart cath. Second, before you do the right heart cath in this patients, it's always good to have a look at the echo to see what are the possible risks or chances of having an arrhythmias. Like this particular patient who is having a largely dilated right ventricle, especially the ARVDs, there is a very high risk of having a peri-procedural malignant arrhythmias. We had one patient had to be put on ECMO when we are doing a right heart cath for an ARVD patient. So you look at that particular list, whether this is a high risk case for doing a right heart cath. Then the next subset is if someone is having a severe RV dysfunction with a tricuspid valve which is not closing at all. Like as you see here, you see things far worse than this. So in this kind of situation, like the ease of passing a catheter through the RA-RV PA pathway may or may not be easy or feasible. So you may have to try it in the ICU or go to the cath lab or try another approach. If not, then you may have to directly go for measuring the LVEDP directly through a left side arterial based study. So identifying the patients in whom the catheter may or may not pass is the third advantage here. Then fourth, you have this particular subset where based upon your echo assessment itself, you will be able to identify there is a severe TR which is non-coapting and it's a low pressure TR. Similarly, if you image, you find that the PR also will be there, which will be severe, and the pulmonary valve also may not be non-coapting. And if you go through a right heart cath, this is what you find. Unless you are seeing that the catheter movement either in the fluoro or in the echo, you see that essentially the traces that you cross the chambers, the right atrium to right ventricle, then from right ventricle to pulmonary artery, they all remain same, the same kind of trace and the same kind of pressures. So that is RA is equal to RVP is equal to the pulmonary artery pressure. These are essentially the patients who are having a severe right ventricular dysfunction. So here the identification is totally by the echo guidance. And fourth, a common issue or a common trouble you can have when you're doing it is you're not able to wedge the PA catheter in this particular patient. In that, again, you have two options, either go for an echo-based assessment of your LA pressure. If it is, otherwise take the patient back to the cath lab and then try to measure directly the LVEDP in this patient. So this is how an echo helps us in guiding the right heart cath procedure in the first step. Then second, once you have your right heart cath and once this data is there in front of you, like in this particular report, second, what we need to do is confirm or aid your right heart cath. What do you mean by when you say confirm? So we have to certainly compare your right heart data with the echocardiography to make sure that both of them match in this particular patient. There should not be any discrepancies. If any discrepancies, we should give it a thought why this particular number or why this echo parameter is different, then take it based on that. To give an example, if you just look at this particular scenario, what I mentioned earlier, if you go for an estimation of the PVR will be falsely low in this particular patient. So that may just give you an impression that this particular patient may be a low risk patient. That if you only identify with the echo and compare that, then only you will get to know that no, this PVR may be falsely low based upon your calculations from the right heart cath. You need to look at some of the possible measures to make sure that this particular patient doesn't have a pulmonary hypertension. Along with that, a serial echoes, in the sense that when a patient is well optimized, totally dried out on inotropes and vasodilators, you may see again a falsely low PA pressure or a low PVR. But if you probably go and refer back the echoes of this patient in the previous admissions or previous data, that may show that the PA pressure may be high. This again is a falsely masking of the high PA pressures in this particular patient, which you're not able to capture at that time when you do the right heart. So one, confirm, aid, and make sure that things are all incongruent when you look at this type of patient is very important. So you have to look at both these side by side and make sure they match in your particular patient. Then the final thing comes, key, how do you use it as a tool along with your right heart cath to decide what are we going to do in this particular patient, the echocardiography. As I mentioned before, this will help you certainly in identifying a falsely low PVR due to an element of severe RV dysfunction, which can give us a false impression that PVR may be low, can consider for transplant. Along with that, the other option which you can look at in this patient is the LVAD. So when we talk about LVAD, what is extremely important is the right heart function. Along with that, you look at all other valves in detail. Most important is the aortic regurgitation, then cavity size, and other things one by one. So to look at your what are the different things you need to assess in the preoperative or in the echo for heart failure in this patients in whom you can possibly consider VAD, you need to do a thorough assessment like this particular guideline from the American Society. You can see that you need a thorough assessment. A lot of parameters have tried to guess or try to see whether we can predict a right heart failure in a patient in whom we can consider VAD, which is your main hindrance of post-procedure or post-operatively. A lot of parameters are looked into it, but in a total aggregate assessment that includes every single parameter of your echo taking into account along with your right heart data is the one that will precisely tell you whether this particular patient can tolerate a VAD or it can have a trouble with the right ventricle in the post-operative period. Next, along with your RV, what is equally important is to look for your walls before you say that a VAD is particularly possible in this patient, like an aortic regurgitation, and also look for the cavity size. Patients who are having a small cavity secondary to infiltrative cardiomyopathies and all, it may be quite challenging to do, or it may not be possible to do. So before we consider these options, we need to look into the echo in detail. Also to look for any possible clots, which make the procedure a higher risk for the peri-procedure event. So this is all what we assess in detail along with your, from the echo point of view, along with your right heart cath, before we decide what this particular patient is for. Is he for a medical management where your echo doesn't look so bad and your right heart numbers are also reasonably okay, or a transplant patient where you have a favorable right heart numbers, which is a lower pulmonary artery pressures and a higher wedge pressure kind of scenario, or a VAD way, which again you look at both of your data with your right heart cath and an echo and then take it based on that. Equally important is like how we go in the pediatric patients. In the pediatric patients, to precisely do a cath study, get numbers and take decisions based on that is quite difficult, and it's not practiced often for multiple reasons, main being the availability of the donors, the complexity of doing a combined heart lung, even if it is a high PVR kind of thing. So more often the decision is based upon echo in pediatric patients. If you see a small child, we may not do cath, but whether this patient needs a transplant, if it is a transplant, are you going to heart alone or go for a heart and lung, that's based upon echo in this patient. So this is how your echo helps in a different level, taking a decision what we're going to do in this heart failure patient. And also in pediatric patients, especially if you're considering a transplant, this will give you a rough idea what particular size donor, the upper limit, what you can consider or accept if you have a donor, a subadult donor or a possibly adult donor in that particular pediatric recipient. So let us look at a commonly used, or the ones which we should do when we see any heart failure episode, whether they are for any advanced therapies or not. The most important benefit from your echo comes from hemodynamic calculations. That is estimating the different hemodynamic parameters. To start with, look at your cardiac output and look at your filling pressures, the right atrial filling pressure, left atrial filling pressure, get a pulmonary artery pressure. And then from there, you derive your parameters, the SVR and PVR. We have different ways of calculating that, the common being your cardiac output using your LVOT and right atrial pressure based upon your IVC measurements and seeing how much is the movement based upon your respiration, and your left atrial pressure, and similarly PA pressure based upon your TR velocities. So this helps in not just identifying the trouble in these patients, but serially following it up. Whether when they are in the ICU or in the ward, will tell you which particular patient is getting stabilized or which particular patient is going down and may need further help in these patients. So next is what do we do? Commonly we do see that a lot of these patients come with decompensating episodes. In spite of all your therapies, slowly as the time progresses, most of them will start deteriorating at some point, and they do come to us with the decompensating episodes. So what are the challenges? These are the main challenges. First is to identify what is this particular patient is having. Most of the time, yes, it can be a decompensation, but what do you also see is a sepsis, so which may present as a deterioration of the heart failure, but it's not uncommon for these patients to have an infection being flared up, which can present as a deterioration in the heart failure, because most of them will be in and out of hospitals. They'll be colonized with the bugs. Having a sepsis episode is reasonably common, or you see that in these patients. Also, does this patient need volume resuscitation? Let us say a patient who is having a heart failure comes back to you with a deterioration, with a low BP and all. There may be some relevant history where you have hiked up your diuretics, or on the other side, he might have had some diarrhea or something. If you just go by the initial or the direct first assessment, you may always see that the particular parameter, what you are looking at, whether you say an IVC or an LA pressure, they're always abnormal. So how do we decide that this particular patient needs just a volume resuscitation? That is by going and comparing with how these patients were before, looking at the parameters before and now, see whether there is a deterioration, see can he be little better with a volume resuscitation, or is this a scenario of where there is a sepsis? Of course, your labs will tell you, but a detailed echo and comparing with before is the one that will really clinch you that is this a decompensation episode, or does this patient needs a volume therapy? If it is a decompensation episode, obviously you're going to go start with your escalating your inotropes or inodilators. Till what point we need to go up? And is there a response to this particular therapies, what you're initiating? Again, that's all totally you need to monitor both clinically and echocardiographic wise. Echocardiographically, as I mentioned before, look at all your hemodynamic parameters, see whether they're getting stabilized. If they're not getting stabilized, probably consider escalating your therapies to the next step before there is a further deterioration there. So once your medical therapy is exhausted, then comes your other options of mechanical circulatory support, the simplest being your IABP. The guidance from taking your puncture to the position and placement is entirely echo-guided. Similarly, for the echo, putting a patient on ECMO if they deteriorate on balloon, right from identifying the vessels to putting the guide wire and positioning the cannula, everything is totally under the guidance of the ECMO. Even after we do that, it's very important to identify that this particular patient does not have an LV distension that leads to pulmonary congestion. And if you have anything, to identify that and find a way to vent the ventricle, whether it is by a septostomy or a direct LV vent or a surgical vent. Again, this entire procedures of doing this is only through the echo guidance along with your clinical this one. So most of these patients, once you consider an advanced mechanical support like an ECMO or a IBP, most of them are not the ones whom you can consider wean and remove it. Most of them are the ones who needs a next level of therapy. But there are also patients who present with acute heart failure, say myocarditis or that kind of subsets, who may need therapies for a short time. But once you support, there's always a possibility for your heart to recover and consider removing that, most often being the acute viral myocarditis or some other drug-induced myocarditis. So there you look at your echo parameters to see whether this particular patient is possibly improving. Better ones are your LVOT VTI, and look at your LV ejection fraction, whether it's more than 20% or not. Once the patient starts improving, that you identify the echo and hemodynamic parameters, then you start coming down and try to make a plan of weaning or removal of the support in this patient. The next one, once these both work out, doesn't work out, is thinking of a temporary support, that is a VAC, that can be an isolated RV or an LV support based upon the patient scenario, or a biventricular support, or an isolated RVAD in a post-transplant or a post-transplant and a post-LVAD scenario. These are the things like what we have seen before. Specifically look at for a PF or an ASD, look for an aortic regurgitation or clots. Like in this particular patient, initially we supported on ECMO and there were large clots everywhere. Finally, we had to do an LA cannulation to convert it into a temporary VAT, since the waiting time was expected to be longer in this patient. Again, everything is totally by your echo guidance. And whereas this one is a post LVAD where who had an RV dysfunction and has to be supported temporarily on an RVAD support there. The other one being a transplant which has a severe RV dysfunction, again has to be supported temporarily on RVAD there. So whatever we do, the identification of that problem, trying to handle that, and once the problem settles down, the attempts to come down further and try to take it out is totally based upon your echo guidance there. And similarly, this is the other support which we are not discussing in detail, the Impella, which is a simpler form of a VAD support there, which you have. So once you have done any procedure, the post procedure, we're talking of transplant or a VAD, we'll not talk in detail, but to briefly look at, this is what we're going to look at any any anastomosis issue, look at the functions there, or look at any possible complications like a collections there, and a graft dysfunction or a right ventricular dysfunction, which is very common in this patient. Similarly, a post-VAD scenario, you're going to look at trying to optimize your flow. How is the septum position? How is your aortic wall opening? Or is there an RV dysfunction? Or is there a collapse of ventricle, a suction kind of events? This is what you're going to look at in your echo in brief or in detail once you do a VAD in these patients. So miscellaneous things, when you have something like a recoverable heart, that is, you are thinking of a mechanical circulatory support in a heart failure patient, and it is a shorter history where there's no increase in size of the ventricle. That is, the size of the ventricle is small. So that's where you think it as a possible support to support them for a shorter time and consider weaning rather than putting them on a permanent pathway of a transplant or what. That again is totally guided by your echo in these patients. To sum up, this is what it is. It is an essential tool, non-invasive and easily available. This is something you try to put in your patient whenever you have trouble and see that helps it at every step in your initial assessment, in your hemodynamic calculations, identifying the decompensations, and doing and evaluating what this particular patient is going to need. And finally, in the care of this patient, even if they have a decompensation, and handling it further down the line. Thank you.
Thank you, Dr. Murli. If you could just switch off the presentation so we can go to our panelists. Sir, would you want to say something before we start the discussion?
Yeah. Thank you, Murali Krishna, for that excellent overview of role of echocardiography in heart failure. You actually told us how it is helpful in diagnosis, prognosis, response to therapy, and in managing life support systems. Thank you so much. And now I hand it over to Rahul and Aditi to initiate the discussion.
Thank you, sir. Thank you, Dr. Murli. I mean, you have talked broadly about the acute decompensated systolic heart failure category and how echo is an important investigative tool in those kind of settings. Just a request, we saw the name of two patients in your presentation. So anonymization is very important for privacy reasons. Would request you to kindly look into that. Now, yes, systolic heart failure echo is a very important tool, no doubt about that. The other important category where a lot of work is being done is the diastolic heart failure in the preserved ejection fraction category. Now, as an eminent cardiac anesthesiologist, how do you feel that the assessment of diastolic failure, how important and how relevant is it to the daily perioperative cardiac care? What is your opinion?
You mean to say when they present with the decompensation or?
Yes, that might happen. It sometimes happens when a little more volume overload happens and they go from one phase of a diastolic heart failure to the next phase. But systolic heart failure, yes, we all know how to measure, how to monitor, but is diastolic heart failure really important in our practice as perioperative cardiac physicians? When Dr. Aditi is coming in 200%, chronic diastolic heart failures and their management in cardiology. But as acute care physicians, do you feel it is relevant, and where echo is a very important parameter in these cases also? What is your opinion on that?
Certainly, we do need that. Certainly, we need to look from that aspect also, because that can be equally troublesome. But to put it like this, I mean, still I can get the question fully. If you're talking of a patient who is already having a severe diastolic heart failure, let me say a severe HOCM or a severe restrictive cardiomyopathy, whom you're talking the baseline atrial pressures themselves being 30, 35 like that, you're talking RA and LA pressures, and then they are going down, or you're talking of how to handle them in the preoperative period. What will tell you more idea? Obviously, your IVC and they're not going to tell us anything more. They're already, by the time you see that they're all going to be in 2.53 centimeters. Maybe what is going to tell you is how bad is the decompensation in them, looking at your effusions, looking at your septal positions, looking at a relative comparison with the previous echo. That's what helps you in this particular patients. That's for this chronic patients. If you're talking of a general perioperative management of a patient who is not sick enough to consider all these advanced therapy, but they come for some other, coincidentally for some other surgery kind of thing, echo is totally needed. Echo along with your filling pressure management, filling pressure guided treatment is totally needed in handling them in the perioperative period.
Okay. Okay.
Rahul?
Yes.
I'm Dr. Sanjeevani.
Hi, Dr. Sanjeevani.
Hi. It was a wonderful lecture, and it was certainly at a higher level for our audience, But talking about your question, which is very, very important, and Murli, what I think Rahul means by his question is not only in HOCM or in LVH patients, but in severe systolic failure, there is always a higher grade of diastolic dysfunction.
Yes.
And that is what I think he means. And in their scenario, treating systolic heart failure is relatively easy, but treating higher end like grade 3 and 4 diastolic dysfunction is relatively very, very tricky until you go on bypass or whatever. So that in that scenario, what is your opinion? That is what I think Rahul means. Is that so?
Yes, of course. But I think Dr. Murli has expressed his opinion on that. I want to move into just one more before I ask Dr. Aditi to come in and give her perspectives in that entire thing. Is we are reading a lot about myocardial deformation imaging, and Aditi would be one person who must be doing it on a regular basis. We are talking about strains and strain rates, both for systolic and diastolic dysfunction. This is a technology which has potential because it has important prognostication markers as well as their independent risk factors for this. Now, as this technology is unfolding as a cardiac anesthesiologist, how do you think is their relevance again of these novel echocardiography parameters in our daily perioperative cardiac care? Is it important? Can we leave it to the cardiologist, or we need to adopt this technology?
Knowing is always good. That's one. Certainly, there is no doubt. Second, your patient assessment is always comprehensive. Our talk for today may be only echo, or we may talk only about advanced echo on a given day. But leave all that aside. If we talk about a practice part, how do we handle that? It's always a comprehensive. And that's what we do see, that as someone with a 20% EF, you may be doing everything in them. On the other side, someone with a 15% EF may be just like going around in an OPI there kind of thing. So that's where it comes. Relatively comparing strains shows a difference. That's where a relative comparison. Commonly, we don't use that much in the preoperative. I mean, we're not talking of that category of patients whom we deal, whom like cardiologist Dr. Aditi deals in OP, in the sense that identification of that the patient has a severe systolic or a diastolic dysfunction. We're not talking of failure or decompensation, dysfunction there, and identifying the underlying cause, trying to make a attempt at the disease or prognostication. How are they going to behave? See how this particular patient is going to behave over a period of time. Are you expecting that over months is going to go down, or is someone you can drag for years together with your medical therapies? All there, it is certainly useful. But if we talk of what we really handle when it comes to that in ward or ICU kind of crisis, when you see this heart failure patients, here it is a comprehensive assessment. A relative comparisons will help. Commonly, we don't use that. We may do a baseline assessment, but if you ask whether we do that every day for your preoperative patients, no. But post-operative patients, yes. Post-operative patients, we do that. They may not come as a heart failure at that point because you already addressed the issue, but that we find it as a very sensitive for identification for a possible reasons for that dysfunction, in the sense that a post-transplant, you see your strain coming down. We then think of whether this immunosuppression is adequate, or you're thinking of a rejection, whether he needs a biopsy. You start thinking on that line. It helps. Those scientifically, based upon your current whatever recommendations, guidelines, they say it's not very conclusive to put it as a recommendation, but clinically, yes, it is useful.
Fantastic. Thank you so much. Over to you, Dr. Aditi, for your question.
I think let Dr. Aditi comment on both Dr. Rahul's questions. Dr. Aditi, please.
Yes, thank you so much, sir, for a very comprehensive talk. And going back to what Dr. Rahul mentioned, so some of these features like strain, myocardial deformation, what you have mentioned, has more of a role in the chronic outpatient setting and not necessarily in the intraoperative setting or in the ICU patients who are clearly in, acute decompensated state. So these were developed, first of all, on transthoracic echo. So that is also important to remember. These have not been developed for transesophageal echo, though you could extrapolate the technology. Also, these are more useful in the beginning stages of cardiomyopathy. Once you already have an established moderately reduced or severely reduced ejection fraction, there is not much more that at least an LV strain is going to add. You already know that they have a severe systolic dysfunction. Definitely, there is a role for RV strain, maybe even left atrial strain, even in these acute decompensated patients. For instance, we use RV strain for assessment of the RV function when we're evaluating for an LVAD, for a durable LVAD alone. So there definitely it has a role. LA strain can also help in acute patients if you are considering cardioversion for atrial arrhythmias. Or you are suspecting that someone may have atrial arrhythmia. So that might be the role in the acute setting, but typically it is more important in a chronic setting, whether it is for screening patients who are receiving cardiotoxic cardiomyopathy, aortic stenosis patients, hypertensive heart disease patients. And then if you're evaluating a patient where we are suspecting infiltrative cardiomyopathy, then the pattern of strain can help in differentiating whether it is amyloidosis, it can be septal, asymmetric HOCM involving the septum. So their strain, I think, has a very important role clinically. Definitely, there are more research-based roles of strain as well. So those are some of the points that I wanted to make.
Thank
Then
you.
for Dr.
But that diastolic heart failure, you want to add anything, Dr. Aditi? Dr.
Yes,
Rahul's
so
first question.
Yes, definitely. So if you're talking about pure diastolic heart failure or heart failure with preserved ejection fraction, that is actually becoming about 50% of patients in the outpatient setting. They don't all always end up coming to a cardiologist. Many of them are being managed by pulmonologists, nephrologists, and their diagnosis of HFpEF is extremely delayed. So HFpEF is a clinical syndrome, as you are all aware, and it is generally associated with a lot of comorbidities. And the diagnosis of HFpEF is also challenging in that it is not just an echo diagnosis, but definitely echo plays a very important role along with your clinical picture. So there is a ESC HFpEF score, HF2 PEF score to help in diagnosing what is the clinical probability that someone has HFpEF. So echo features are included in that definition as well. So echo features such as LV hypertrophy, presence of diastolic dysfunction on echo, which we have very nice guidelines from the European Society as well as ASC as well regarding assessment of diastolic function. That includes the EE prime ratio, the TR velocity, the LA size. So we use those for a comprehensive assessment of diastolic function. And exercise echo also has a role. It was favored more strongly a few years ago. Now we are realizing there are more challenges to it, but exercise echo also has a role. So you may have normal diastolic parameters at rest, but with exercise, you can see exercise-induced pulmonary hypertension, exercise-induced increase in your EE prime ratios. So that can also help you make a diagnosis of HFpEF. But again, these are more in the chronic setting, not so much in the acute setting.
I had a question for Dr. Aditi, and I thought I would keep it for last, but since we are in the flow,
Not audible.
we are reading papers about how AI is coming in the field of
So actually, this is a very fascinating field, and I have to confess that I am not super abreast on all that is happening in the world of AI. Dr. Deepak Padmanabhan is actually working a lot. But recently, there have been a few very interesting papers that have come out of Mayo about using AI for diagnosis of HFpEF, actually, because systolic dysfunction is relatively more straightforward. But HFpEF again is a very complicated diagnosis. So there is an algorithm using just echo images that Mayo has come up with and was published in JACC as well, where they have validated this in an internal population as well as external population. So if the AI algorithm is installed in the machine itself, echo machine itself, and it looks at several hundreds of parameters to help in diagnosis of HFpEF. There is work that is being done at Narayana also using AI. Right now, we are focusing more on ECG-based use of AI, but definitely echo is a field that is going to come up more and more, and there are other companies also working on it. For instance, using AI to diagnose systolic, and we are already using technology to some extent, for instance, in 3D echo to help in quantifying mitral regurgitation, tricuspid regurgitation. So those are all, those are all technological uses that are commercially being used as well already. And definitely a lot of research is being done to help in better prediction, better quantification and assessment.
Yeah, that's great.
Aditi. Yeah.
Can I make
There are a few
There are
questions
a couple,
on the
yeah,
chat
there are a
box.
couple of questions. Do you want to take them before I make comments, or shall I make a couple of comments?
Sir, you have the comments, then we'll come to
I will just
Yes.
make a quick comment about diastolic dysfunction. Echocardiography, we do the E by A, which tells us about the restrictive pattern in advanced diastolic grade 3 or grade 4 dysfunction. E by A greater than 2 has a poor prognostic significance, and also E by E, this was mentioned by Aditi, E by E is also a very important parameter when you're talking about severe forms of diastolic failure. And regarding strain, heart failure with preserved ejection fraction, strain may be, even though the ejection fraction is maintained, strain may show abnormal values in these patients who have heart failure with preserved ejection fraction. And early strain is also coming up in a big way in diagnosis of diastolic dysfunction. This was discussed in one of the talks last time when Deepak Bode was presenting about early strain. Regarding artificial intelligence, so we have the some of the machines which automatically read the ejection fraction, LVOT, VTI, etc., which has been compared with the parameter derived by the experts, and it was found to be having excellent correlation. So, as Aditi pointed out, AI is making its way into echocardiography, and we are going to see it soon in diastolic dysfunction assessments. With that, we'll go on to the chat box questions.
Yes, sir. Sir, I will read them out.
Yes.
To Dr. Murli, the first question is the emphasis on identifying the cause of decompensation and the use of trend in hemodynamic calculations of echo, of course, is much needed. Do you have any experience with the use of total vein pulsatility for following the hemodynamic trend and what?
Honestly, like, no, we don't use that as a regular parameter. No, honestly, like, we don't use that as a parameter.
For the right heart functions. But...
Hello.
Okay, yeah.
Yes, we don't regularly use that as a parameter. Like, basically, that will probably tell you that whether this particular patient, volume-wise, can take some more, or you have reached your limit. Is that that's that you can do? You think of more an anatrop, anodilator, or something more than that. There, we don't regularly use that. We go with your more of with IVC alone. But yes, it is important in some scenarios, more so if your patient has a combination of hepatic and cardiac together. There, I think it makes a difference there.
I think its role is mostly in right heart failure.
Right heart failure, basically.
Right heart failure. It gives an indication. Usually, the flow is not pulsatile, but in right heart failure, especially in presence of tricuspid
Tricuspid regurgitation, it will pulsate, yes.
Yes, absolutely.
Aditi,
Agreed.
do you want to say anything about pulsatility index, portal vein pulsatility in right heart failure?
Yes, I mean, these are, I think, parameters that you would use in conjunction with other echo parameters and clinical parameters, the portal vein pulsatility as well as renal vein
Yes, resistive index.
Yes.
System.
both
Brain
of those, there is some role in there is some data to suggest that the renal vein flow patterns can help in predicting whether the AKI is going to improve or not. So that would be one thing that can be followed.
Right.
Muralidhar, can I say something on
Yeah,
this?
please.
This is actually part of VEXUS scoring, and one of the, I think
Yes.
Ratan had asked this question.
Correct.
Yes.
Certainly, when our right heart is severely failing, distal organs show pulsatility.
Yes.
So, distal hepatic vein, renal vein, as Aditi has said, and even during operation, I think this can be diagnosed, and we know that the right heart is failing very badly, and we can act accordingly. So it's a very simple method, but to know the severe dysfunction of right heart.
Yes, that's right. When we do the pulmonary endarterectomy, we always notice that portal vein pulsatility index. Patients
Good
have right
question.
heart failure.
Good that it brought to our discussion the VEXUS score. And yes, a certain kind of a conversation is also happening in this new parameter. So good that you raised. The next question is also very interesting. Incidental PFO by echo in heart failure patients. What do we do? I mean, we have been discussing about incidental PFO for donkey's years in various cardiac surgery. If they are found, what do we do? But in a decompensated heart failure, we do echo and we find a PFO. What would be the good management?
If you're talking purely of a PFO in a patient with heart failure, I mean, let us look at different scenarios there. You're talking purely of a PFO and you're talking of an LV failure with a high LA pressure. I think that should not make much difference. It's a PFO, it should not shunt anyway. Just it will just be non-functional there, kind of thing, that we can leave that. A PFO in an RV failure, you can still think it as it is helping you. That may act as a pop-off there. The patient may not decompensate as quickly as he will in without a PFO. Probably that helps you there. There may be a bit of desaturation, which is very well acceptable. Probably that gives you a little time for you to settle down that patients if you're talking of an acute crisis time there. That's further the RV failure. Then third comes in your importance of identifying that, especially if a patient is going for one of the ventricular assist devices, whether you're talking of a temporary or a permanent, whether you're talking of whatever it is, a right ventricular or a left ventricular. It is very important to identify that. It may be easy to identify, as I said, in a right heart failure. If you're doing a temporary, it will just suck out everything from your left side and just becomes a blind loop there. In your LVAD, it becomes even more important because you have to unmask it in the presence of a high LA pressure, which you specifically have to look during the surgery in the preoperative period or in the preoperative evaluation to identify whether a PFO is there.
Fantastic. I think you dealt with all the possible conditions that can come in heart failure. Dr. Aditi, you want to add anything more as your advice to the surgical team about what to do?
Yes, so generally, if it is truly an incidental PFO, nothing really needs to be done. And this is extremely important to keep in mind, particularly in patients with RV failure and pulmonary arterial hypertension. Every now and then we'll get a patient who actually had probably a stretched PFO because of the RV failure, and someone has decided to go and close it, and then the patient actually starts getting worse after that and arrests. So it's very important not to do anything about these incidentally detected PFOs. It's probably a stretched PFO, and it is actually helping the patient, as sir has mentioned. Once in a while, you'll actually find that it is a ASD and maybe the reason for the right heart failure, but definitely you need to do a full evaluation To determine that there is a significant shunt, you have to calculate the QPQS and actually see that this is the reason for the right heart failure. So it is important to distinguish between whether it is an actual ASD or just a stretched PFO.
That's a very important point what Dr. Aditi has said. I mean, to put it in this perspective, a patient may just come the first time to your center. The echo just shows there is a septal defect, there's a pulmonary hypertension. Is this a primary pulmonary hypertension where the septal defect is keeping the patient alive? Or is this an ASD which was undiagnosed till now, has become an Eisenmenger, where you can still think whether you can try something to bring down the PA pressures or any other measures. It's very important to identify which particular category the patient falls into. Otherwise, I mean, you can it can lead to catastrophes in your handling there.
Absolutely true. Actually, when there's a ASD and pulmonary artery hypertension is there, to close the ASD or not is a big dilemma. Actually, we can land up in soup if you close a VSD where there's a component of primary pulmonary hypertension. The patient will promptly land up with right ventricular failure. We have had one or couple of instances, and what sometimes we do is reduce the size of the ASD and then do a device closure later if it is needed at a later point of time. Don't close the ASD completely in such patients. Do you agree with that, Aditi?
Yes, sir, definitely.
Yeah.
If you think that the ASD is the cause of the pulmonary hypertension, if they already have severe PH, then we don't want to close the ASD completely. You can do a fenestrated patch.
Exactly.
Yes.
Can I say something on this,
Yes, yes. Rahul and Aditya are the...
Rahul
No, sir, of course. Yes, ma'am. Please go ahead.
About this PFO or small ASD, the new thing is coming up that for severe diastolic dysfunction, they are creating one.
Yes.
Aditi, if Rahul or Aditi or Murali can throw some light.
Yeah, you're right. Actually, in pulmonary hypertension, especially chronic thromboembolic pulmonary, one of the treatment options where the patients are not fit for actual surgery, they are doing septostomy, but I don't think if it's being done routinely. To maintain the forward output, if the pulmonary vascular resistance is very high, where right ventricle is not able to generate that much pressure to pump against the high pulmonary vascular resistance. This is mentioned as one of the treatment options, but this is not the curative, of course.
Yes,
Yeah,
sir.
I
For
agree.
diastolic dysfunction, I mean, for diastolic dysfunction, severe diastolic.
Same thing applies to other.
Diastolic dysfunction. Okay.
Yes, sir. So recently the LAP-HF trial was published where atrial flow regulator device, the AFR device, is being studied in patients with HFpEF. So there it serves as a pop-off for the high left-sided pressures essentially. So that still remains to be seen whether it is beneficial or not beneficial.
Right.
Very interesting.
On the other side, a couple of patients with primary pulmonary hypertension at an appropriate time identification, atrial flow regulator is used as a therapy. But again, disease should not progress to a phase where you do that, it just kind of totally takes away everything from the right sides and patient crashes. The clear criteria when we should consider that atrial flow regulator. And almost most of the transplants where we anticipate that there can be a PAH or a possible RV dysfunction for some reason, surgeons always create a small hole in the septum, intra-atrial septum, and that certainly helps. That's what we have seen in our clinical practice, what we do in our place.
Fantastic. We got a lot of insights into this very interesting thing, and of course, more data is needed. We'll go to the next question, and Dr. Sirisha is asking what parameters of echocardiography suggest for surgical intervention in heart failure. I guess it's not echocardiographic parameters, but more a clinical decision, and at what point of medical therapy and management the patient is in, whether it is becoming refractory to medical management, and that's when we start considering about the surgical treatment. Dr. Aditi, would you agree with that one?
So there is a broad spectrum when you are saying just surgical intervention. Are we talking about CABG in ischemic cardiomyopathy? Are we talking about mitral valve surgery? Are we talking about aortic regurgitation and surgery? or we're talking about durable LVAD and transplant. So each of these can be a whole lecture in itself. When we're talking about ischemic cardiomyopathy and CABG, then the data on this is evolving, and more recent data suggests that once you have severely reduced ejection fraction with an EF of less than 30-35% or so, then even if there is viability, then doing CABG or doing multi-vessel PCI does not seem to help. So it seems that once you have severely reduced ejection fraction, then the primary pathology is less important, whether it was, CAD, and now it's more of a ventricular problem. So even doing CABG does not seem to have a morbidity or mortality benefit. That is what the newer data is suggesting, even without viability, but definitely a full assessment is needed for this, clinical signs and symptoms, how the coronary anatomy is, whether there's viability or not, all of these. And echo can definitely help in deciding that also. If your walls are already thin, akinetic, you can do you can test for contractile reserve also, and use all of this information in deciding whether to pursue revascularization or not. Similarly, for mitral valve intervention, if even if you have a primary mitral regurgitation, that is because of a mitral valve problem, whether it is mitral valve prolapse, once the EF is severely reduced, the guidelines suggest not operating on the mitral valve once the EF is less than 30%. Similarly, for aortic regurgitation, once the EF is less than 30%, then they don't have good good medium term and good long term prognosis. So that is where echo is extremely beneficial in all of these categories of patients. And then definitely echo parameters are helpful in understanding how somebody's prognosis is going to be and whether they're going to need advanced heart failure therapies. So extremely dilated ventricle, large area of remodeling, large akinetic or aneurysmal segment, severe functional MR, functional TR, high PA pressures, all of these can suggest that you're dealing with a patient with advanced cardiomyopathy and they should be considered for LVAD or transplant. So big spectrum of, surgical interventions that are being used in heart failure. And there are percutaneous interventions also, in addition to PCI now, like mitral clip or TAVI for low flow, low gradient AS. And again, there echo plays a crucial role in assessing whether these percutaneous interventions are going to be beneficial or not.
Fantastic. Sir, we are exactly at 10. We have crossed 10. So over to you, sir.
Is there any last question?
We have already, Dr. Ratan Gupta is asking about vexels. We have discussed about that.
Yes.
Dr. Karthikeyan is asking how to detect high pulmonary vascular resistance in severe RV dysfunction. Dr. Modi, you want to take that?
So that will be the last question.
Yes, that's very tricky in the sense that you have to look for it if you have to pick it up. It starts with your full evaluation of your patient. Let me tell you, 2-3 scenarios. One, a patient who at some point had a normal pulmonary artery pressures, then they went up, and as the PA pressures went up, there was a progressive course where the PAs were high. Then eventually RV for some reason got dysfunctional, whether it's an intrinsic disease or secondary to the PA. Then you have a falsely low PVR calculated because of your RV failure. In that situation, or a second situation where you do see at times children who may have the disease of the DCM, maybe in utero or right at the time. Even the first time when they're screened, when they're months also, you see that they do present with a biventricular dysfunction there. So when exactly did it happen to start with? Is it a disease of only an LV at some phase, whether it is in utero or beyond, where the lungs became bad and that became an RV failure down there? So how do we identify that? We identify that by few parameters. One, basically go through and review the records in detail, every small single record what the patient have an echo done few months back, few years back, will probably clinch you at that. Okay, what is this? Is it at some point RV dysfunction was there, or PA was high, or no kind of thing? Second, an X-ray can help you. Okay, how is the vasculature in that X-ray? Is there a peripheral pruning and all that can identify you? Probably a precise way of doing it is a lung biopsy, which can tell you, but practically How frequently it is done, at least we have not done. We just go by these parameters and try to identify that. Maybe an inotrope challenge or all these things, but we are talking of a very severe RV which is beyond all this phase. I mean, you start some inotrope, it gets better. No, it has crossed all of that stage. An RV which is refractory to all these, where the tricuspid valve is even in systole is having a gap between leaflets of a centimeter or maybe more than that kind of thing. That's severe RV we are talking about. Dr. Aditi, you want to add, please?
Yes, so we can use other hemodynamic parameters like PAPI that can assist you in telling you whether you are dealing with severe RV dysfunction, and that's the reason the PA pressures are falsely low.
PAPI, okay, okay.
PAPI, RV stroke work index. Essentially, your PA pressures are falsely low because the RV is not able to generate any pulmonary pressures. That is how severely dysfunctional it is. And then your clinical parameters will also tell you the patients will have signs and symptoms of RV failure, ascites, edema, high liver function tests, high renal function tests. So we have to take the whole picture into consideration.
Rahul, Aditi?
Yes, ma'am. Please come in. This is a very tricky question and a very interesting question.
Yes.
So please come in.
Can we do simple like RVOT VTI and then acceleration time, which is also very indicative of high PA pressure and then indirectly high PVR?
Yes.
Because it is very simple to do on during surgery, if acceleration is less than 60, certainly there is tremendous resistance ahead. Acceleration.
So I guess the question partly also alludes to intrinsic RV dysfunction, which is leading to poor cardiac output at the RV end. So that is where the problem is arising, that if you don't have the cardiac output, how do you measure the PVR? I guess the question lies there. But very interesting that Dr. Aditi mentioned PAPI. And yes, that would be a very interesting thing to look at. Sir, you want to say something in this matter?
No, I tend to agree with Sanjeevani to some extent, saying that pulmonary acceleration time and RVOT VTI may also give us an indication of what is going wrong with the right ventricular pulmonary artery cupping and the right ventricular pressure and the relationship with the pulmonary artery pressure. So with that, I think it's time to conclude, and I would like to greatly express my gratitude to Dr. Murali Krishna, Dr. Rahul, and Dr. Aditi for joining us this Sunday. We have enriched ourselves with the presentations and following discussion. And with that, we would like to conclude today's session. Have a great Sunday. Before concluding, I think Rupta will play the video regarding the forthcoming PE workshop. Please join us.
Okay, sir. So I'm playing the video.
Thank you. Thank you so much.
Thank you. Thank you, Dr. Murali. Thank you, Dr. Aditi. Thank you, sir, for organizing this session.
Thank you, everyone.
Thank you, Dr. Sanjeevani, for very excellent.
Thank you, Rahul. Thank you, Murali.
Thank you so much, everyone, for your patience listening. And thank you for extending us the opportunity to host this session. So with this, I would like to conclude this session over here and looking forward to host you again. Thank you so much, everyone. Thank you so much, sir. Have a great
Thank you.
Sunday.
Thank you so much. Thank you.
Thank you. Thank you and
Thank you,
bye.
sir.